Welcome to the Alliance's Stomach Cancer and Peritoneal Metastasis Advancing Treatment Through Clinical Trials webinar. I'm going to go through a few housekeeping slides before we begin. First, I'm Amy Hanley. I'm the Program Director for the Alliance, and I am going to tell you about a few things before we start. The webinar will be a short presentation. We received several questions from registration and have worked to answer those throughout the presentation. If you have any additional questions throughout, please use the Q&A box to send to all participants, and we'll try to get to those as time allows. All lines are muted for noise reduction, and the presentation is being recorded. It will be available through the Alliance's website, on our YouTube channel, and will also be shared via social media. Finally, if you have any question about this event or any future events, please contact me at the email listed at the bottom of the slide. So I wanted to share a little bit before we begin about the Abdominal Cancers Alliance. It's an independent nonprofit connecting and empowering the abdominal cancer community to see that every patient receives appropriate and timely care throughout their cancer journey. We work to connect the larger abdominal cancer community to patients, resources, and ensure that we improve and save lives. We do this through three means. First, by raising awareness with the public and care providers, making connections to resources and care, and guiding patient and caregiver navigation throughout the cancer journey. The Alliance has an established central information system of resources on our webpage, as well as through treatment options such as CRS HIPEC. I also wanted to make note of some of the resources the Alliance makes available. The Alliance provides information on treatment such as CRS HIPEC and survivorship resources, such as recent resources on nutrition, HRT, financial assistance, social support, as well as many others. Please check out our offerings as we're often adding new throughout the year. And with that, I want to introduce you to today's speaker. Dr. Senthil is an internationally recognized surgeon scientist who specializes in the management of patients with peritoneal carcinomatosis. Dr. Senthil is a professor of clinical surgery and the chief of the Division of Surgical Oncology at the University of California, Irvine, and is the director of Peritoneal Surface Malignancy Program. The overarching goal of her work is to improve outcomes of her patients with peritoneal malignancies through innovation, research, and technical excellence. Her research is focused on challenging the treatment of diagnostic paradigms of peritoneal carcinomatosis. Dr. Senthil is a principal investigator of the NCI-funded trial STOP-GAP, a phase 2-3 clinical trial that is evaluating the new strategy for combining interperitoneal chemotherapy with systemic therapy to treat patients with gastric peritoneal carcinomatosis. And with that, I'm going to turn it over to Dr. Senthil. If you want to start sharing your slides.
Yeah, thank you very much, Amy. Thanks for that kind introduction. And as I mentioned, I appreciate this incredible opportunity to be able to share what we are doing to improve the outcomes of patients with gastric carcinomatosis. Such a key area that needs a lot of attention and focus. So the opportunity to share this information with the group as well as a larger audience is so wonderful. Okay. Good morning, everyone. Thank you for those who have joined the webinar. It's incredible to have your precious time to share the trials that we are doing to improve the outcomes of patients with gastric carcinomatosis. So I truly appreciate your attention to this work. As Amy mentioned, the core purpose of today's talk is specifically focusing on some of the clinical trials that we are doing to improve the outcomes in patients with gastric carcinomatosis. Now, let's start with, these are my disclosures. Let's start with how big of a problem is gastric cancer itself. So gastric cancer is a global health problem. So stomach cancer, as it is called, is a global health problem. It is actually the fifth leading cause of cancer deaths across the world. Fifth leading. And so that's a big number, almost 600,000 deaths per year. Some of the Asian countries have a much higher incidence of gastric cancer compared to the US. So, as you can see in China, it's almost 13.7 people per 100,000. In Japan, it's actually doubled, whereas in the US, it's 4.1. Right? It's much lower incidence. Stomach cancer has a lower incidence in the US compared to some of the Asian countries where gastric cancer screening is actually routinely performed because of that high incidence of stomach or gastric cancer in those regions. We don't have gastric cancer screening in the US because it's not as prevalent as it is in the Asian countries. But what is the issue in the US currently that we are faced with? Gastric cancer incidence is on the rise in the US. Since 2019, we have seen an uptick in the incidence. So, what this graph shows you is male and females in the US and the incidence of gastric cancer. The line actually shows how the incidence is. And you can obviously see there is an upward rise in this line, showing that there is an increasing incidence of gastric cancer, particularly in women. From 2019 to 2022, so this data is up to 2022, there is an annual percentage change, which is how we assess the change in the incidence of any cancer, has gone up by 6.2. So there is, although globally, when we look at the incidence of stomach cancer, US is not the most, dominant player in the overall incidence of stomach cancer. The raising incidence or increasing incidence is worrisome in the US. Now, what is even more worrisome is how often do these patients present with advanced, meaning stage 4 gastric cancer? When we look at the incidence rates by stage in the different states, right? So this is stomach cancer, only the late stages that I'm showing you. One third of patients present with stage 4 cancer. Now that's a very high number, extremely high number. Even if we say about 30,000 new cases, almost one third of the patients, that is 10,000 people, will present with stage 4 gastric cancer when they are diagnosed. Right? That's a lot of young people, and oftentimes this happens in younger cohort. And as you can see the distribution here, this is the map of US, and all the red spots, the big red states, have the highest incidence of that stage 4 gastric cancer. California is being one of them. And I practice in California. I'm a professor at University of California, Irvine. So we see a lot of young people come with stage 4 gastric cancer at the time of their diagnosis. And oftentimes, stage 4 gastric cancer is usually peritoneal carcinomatosis because gastric cancer has a predilection to metastasize, meaning the cancer spread happens in the abdominal cavity. This is a laparoscopy image of a young woman with gastric cancer, and all of these white dots that you're seeing is cancer spread. That is diffuse peritoneal carcinomatosis. And that's what we see when we put a laparoscope in these patients when they are presenting to us and we are trying to understand what stage at which they are presenting. This is often the unfortunate picture that we get to see. 30 to 40%. Right? So of the patients who are presenting with gastric cancer, about 30%. So this is a very high incidence of stage 4 disease, is peritoneal carcinomatosis. Now, taking it one step further, okay, gastric cancer is increasing in the US. One third of our patients present with stage 4 cancer, and oftentimes it is peritoneal carcinomatosis. What is even more bothersome is peritoneal carcinomatosis has the worst survival of all metastatic sites, particularly in gastric cancer, and the survival is only 6 to 13 months. 6 to 13 months. Imagine that. You have a 32-year-old mother of 4 in your clinic, and you will have to discuss this number with that young mother, it's very hard to be able to go through that conversation without having a sense of anger about the helplessness that these people would feel or the sadness that they would encounter, right? And the problem is their poor response to systemic therapy, meaning just IV chemotherapy alone by itself may not be sufficient because of the nature of this disease. And as you can see, these are white patches. They are flat. They are not often seen on CT scans very clearly. And the amount of blood supply to these tumors are questionable. And hence, their response to systemic therapy or the penetration of systemic therapy into these tumors is always questioned. And so, better therapies are needed. There's no question at this time that better therapies are needed for the management of patients with gastric, stage 4 gastric cancer, gastric carcinomatosis. And that was clearly the impetus for me to get involved in systematically looking at how do we improve our outcomes for our patients, is because I practice in a state where every single day I got to see young people coming in with stage 4 cancer. And this number wouldn't cut it. 6 to 13 months, I'm not going to sit there and tell my patients that 6 to 13 months is all that they have. Right? That's unacceptable. That is truly unacceptable. And so, I started really looking into how do we improve outcomes? What is that we can do? And pretty much all of my work, whether it is in the clinic, in the operating room, or in my research lab, is all focused on this one singular goal, is how do we improve outcomes? Right. Now let's think about, I mentioned a statement that systemic therapy has poor response. Now, what about systemic therapy plus surgery, where we offer surgery and remove the cancer? How has that fared in the literature? Right. Now, what has happened is many people have tried to do this, and I'm going to show you 3 separate trials. And all of these 3 trials, they are called as Renaissance, Periscope, and Gastropath, you name it, right? All of these trials did one thing. What they did was they did give chemotherapy, but only gave it for 3 or 4 cycles, tops, and then offered surgical removal of all the cancer in the abdomen. This did not fare well. This was not a useful strategy, is because when they tried to do surgery in gastric cancer after a very short duration, so 4 cycles is just 2 months. 2 months of chemotherapy was not sufficient, and all of these results, all of these studies were negative trials. When they attempted to offer surgery to patients with stage 4 gastric cancer after a very short duration of intravenous chemotherapy. Right? So this is an important lesson we have to learn when we think about how do we manage these patients, right? Yes, systemic therapy is not as great, but systemic therapy is a critical part of gastric cancer treatment, and especially gastric cancer stage 4 treatment, including peritoneal carcinomatosis. So it is not to be discredited. The general belief is that it has poor response to systemic therapy, but the systemic therapy itself is improving in gastric cancer. We have newer and newer agents that are being added to the treatment of stage 4 gastric cancer. So what might have been the case a decade ago is not the case now. So we need to reevaluate our approach in managing patients with gastric carcinomatosis with the newer agents that are coming in, including immune checkpoint inhibitors. Like, for example, there's a new agent that was approved last November, zolbetuximab, which is a specific monoclonal antibody. So there are always combination agents that we are using. So this is just to further emphasize the results of those negative trials. So essentially, for those who are not familiar seeing these type of curves, all that you have to know is that typically these two should separate if that's what you're trying to prove. Unfortunately, both the experimental and the control arm in this case, and they were trying to see how HIPEC worked in these situations, it didn't do well. There was overlap, and the median overall survival was 14.9 months, and it was close for poor accrual. And the more recent trial, which is the Periscope 2, again, overlapping curves, which means that there was no difference between what they were trying to prove with cytoreduction. So Periscope 2 was trying to offer surgery to patients who had stage 4 cancer after 3 to 4 cycles of intravenous chemotherapy. That strategy didn't work, right? So the question is, what do we do about it? What do we do about this? People are trying to improve the outcomes, but the current approach and strategy doesn't seem to work for them, right? So let's think about it at a more fundamental level and say, what is unique about peritoneal metastasis? Why is this so different? The reason why it is different is, one, the anatomy of peritoneum itself creates a barrier. So here is location of tumor, here is location of blood vessels, and this is the blood peritoneal barrier, which is a collagen fiber plate that creates that barrier through which anything has to go one way or the other. So when chemotherapy is being administered through the blood vessels, this chemotherapy has to pass through this barrier to get to the tumor. So the concentration of how much chemotherapy might get to the tumor will vary based on the nature of the tumor, how deep the tumor is penetrating into the blood vessels region, like how invasive these tumors are. So there is an inherent challenge that we have to continuously keep in mind when we are managing peritoneal carcinomatosis because of the anatomy of peritoneum. And then there is also the biology of the tumor itself, because these are very dense tumors with confused blood vessels in them. So they may not get as much concentrations of chemotherapy compared to a metastasis in the liver, where there is a very rich blood supply. So that's also part of the challenge. Now, you can take the same issue, right, the blood peritoneal barrier, and flip it on its head and say, so on the same token, if I administer something into the peritoneal cavity, less would go into the blood circulation because of the barrier. So the rationale is you can put chemotherapy agents into the abdominal cavity, into that peritoneal cavity at a very high concentrations, and expect that chemotherapy will stay in the peritoneal cavity and not get absorbed into the blood circulation because of the same barrier. Because anything that goes back and forth has to go back and forth through this blood peritoneal barrier. So if we put chemotherapy into that abdominal cavity, a lot of that chemotherapy has to be retained into that abdominal cavity, which is what is shown in this graph. So this is basically the concentrations of paclitaxel. Paclitaxel is a chemotherapy agent that is used in the management of gastric cancer and many other cancers, but in gastric cancer. So here this graph shows paclitaxel being administered into the peritoneal cavity, and they are looking at how much of it gets into the blood. So the bottom line here is how much of it gets into the blood. Very little gets into the blood. And this is about 24 hours after the administration of paclitaxel. And most of the paclitaxel, you can see the concentration is still maintained. You can see that line, it's very steady, it's there. The high concentration that you're administering is still maintained in that peritoneal space. So it is bathing that tumor, it is acting on the tumor at a very high concentration, still being retained into that peritoneal space with very little getting into the systemic circulation. This is the biologic rationale for administering chemotherapy directly into the abdominal cavity, meaning peritoneal chemotherapy. Now, peritoneal chemotherapy can be administered in many ways: heated intraperitoneal chemotherapy, pressurized intraperitoneal chemotherapy. The other form of chemotherapy that we administer is called as normothermic intraperitoneal chemotherapy, right? Which is just like you get IV chemo, it goes into the abdomen under normal conditions, as if you're sitting on the infusion chair, getting chemotherapy into the IV and getting chemotherapy into the abdominal cavity through a port. So that is the normothermic intraperitoneal chemotherapy. Now, I bring this up is because this normothermic intraperitoneal chemotherapy is so easy to administer. It doesn't require surgeries. It doesn't require repeated operations, because the HIPEC and PIPAC that we talk about every time it is administered, the patient has to be taken into the operating room. Whereas with normothermic intraperitoneal chemotherapy, it is just an outpatient infusion, like the chemotherapy that the patients are already getting. Makes it logistically so simple and easy for the patients to be able to take this treatment for multiple cycles, right? And this has been tested in Asia. The normothermic intraperitoneal chemotherapy has been tested in Asia. So the question that we have is, can the chemotherapy, the IV chemotherapy that we administer, can it be augmented by administering chemotherapy also into the abdominal cavity? It's called as bidirectional therapy because you're attacking the cancer from two directions. One is the intravenous direction, the other one is the intraperitoneal direction. So you're hitting it from both sides. So whatever advantage you get with the systemic therapy you get, and then you also get that additional augmentation by having chemotherapy also bathing this tumor in the peritoneal cavity. So that is the bidirectional and normothermic intraperitoneal chemotherapy. Now, there is precedence to this approach by a Japanese group, and they did this trial. These results were published in, like as you can see, in 2018, the results of this trial were published. Now, this was primarily putting in, as you can see here, intraperitoneal and intravenous paclitaxel in patients with gastric cancer with peritoneal metastasis. That's what this group tried to do. And Dr. Ishigami showed these results. Now, the main thing was the primary outcome of this trial did not reach significance because they were not able to show that the overall survival was significantly different between the groups. There were some issues with the trial and crossover and many things, but it did show a strong signal. What they were able to show in the Japanese Phoenix GC trial is that patients who received intraperitoneal chemotherapy, the 3-year survival rate was much higher than the patients who did not. 22% versus 6%. Right? So there was a signal, even though the primary endpoint of the trial was not met, and that is how we classify a trial as a positive trial or a negative trial. It's binary classification that probably is not the right way to look at trials, but however, such as the scientific analysis. So it was a negative trial because it did not meet that endpoint of overall survival. However, it showed a strong signal. Subsequently, there is now a new randomized control trial from China called as Dragon 1 trial using the same exact concept of systemic therapy and intraperitoneal paclitaxel. It is intravenous and intraperitoneal paclitaxel. And finally, this trial was able to show a difference in overall survival. And this was statistically significant. These results are now published in JAMA Oncology, and they showed a survival of 19.4 months in the group that received the intravenous and intraperitoneal paclitaxel. And now, in this trial, they offered surgery to patients who had great response. Let's look at the results of the patients who underwent surgery. So this is the result of the patients who were able to get treatment and were able to undergo surgical resection. Median overall survival of 10.1 for the group that did not undergo surgery versus 30.3 months for the patients who were able to undergo surgery. This includes all of patients. So I'm not saying that it is only for the experimental or the control arm, includes all patients here. So all of the 222 patients who were enrolled in the trial were included in this analysis. And what it shows is that surgical resection in appropriately selected patients with gastric carcinomatosis still has benefit. And they showed that, of course, in patients with intraperitoneal chemotherapy, that this difference was much higher, but definitely showed the feasibility of surgery in patients with gastric cancer, peritoneal carcinomatosis, and the improved survival associated with the conversion surgery in patients who respond. So there was a selection associated with it, unlike the European trials, which is important to keep in mind. European trials did short duration of systemic therapy alone and cytoreduction with a single intraperitoneal chemotherapy, whereas the Asian trials did bidirectional approach And they selected patients for surgery based on the peritoneal disease response. Right? And these are important learnings from these various trials that are happening in the gastric cancer peritoneal carcinomatosis space. So what we can say is bidirectional therapy followed by conversion gastrectomy, which is the surgery, is associated with significant survival benefit in Asian patients with gastric carcinomatosis. And we know that the biology of gastric cancer between Asian population and Western population is very different. It's not the same cancer. Even though we call that a stomach cancer, they are different cancers. So we need to assess this approach in Western patients. And this is why I started with the collaboration with one of the medical oncologists at UCI, Dr. Dayani, a phase 2 clinical trial. So this is STOPGAP 1. And this trial was essentially to establish the safety and feasibility of this bidirectional approach, giving systemic therapy and intravenous intraperitoneal paclitaxel in patients with gastric carcinomatosis. And the reason to do this is that this approach has fallen out of favor in the US after an ovarian trial that was done almost 2 decades ago. And hence, we really needed to establish whether it is safe, whether it is feasible, how do patients handle this treatment with the treatment that we give, because the IV treatment in US is very different from what is used in Asia, in Japan, or in China. It's very, very different. We use a lot of monoclonal antibodies and targeted therapies in gastric cancer treatment, such as the immune checkpoint inhibitors, which is nivolumab, pembrolizumab. Those kind of treatments are often included with the systemic treatment we give. So our systemic treatment is very different, and we need to check with our systemic backbone, can the intraperitoneal paclitaxel be safely administered in our patients? And so this is the trial schema of the STOPGAP 1 trial. I will not go into too much detail, but the idea behind this is that we selected patients after 3 to 4 months of their initial systemic therapy, meaning intravenous chemotherapy, and made sure that they only had peritoneal disease, and then put a port. So here is an image of the intraperitoneal port. It is just like any other IV port. It's an intraperitoneal port, and then the catheter just drops into the abdominal cavity. This is what the nurses access when the patients are in the outpatient center, to just put the needle in and give the chemotherapy into the abdominal cavity. Very simple. It's administered by nurses. It's not administered by surgeons in the operating room. Right. So we put this port in and gave the patients 3 months of IV and intraperitoneal chemotherapy, paclitaxel. Here is the regimen we used for STOPGAP 1, and targeted agents were allowed. So all of the wonderful advances that we have in gastric cancer management were included in the treatment of these patients. And we grouped them into 3 groups. They can continue the treatment if they had response, but the disease is too much for me to offer surgery. They were offered surgery if they had response and the disease burden was low enough and was conducive for me to completely remove. We offered surgery to them. So that is the CRS HIPEC group, cytoreductive surgery plus heated intraperitoneal chemotherapy at that time of surgery. And if the patients had progression, they switched to a second line agent. Right. So this was very simple, straightforward algorithm, and you're just making decisions based on how the patients are responding to the treatment. We enrolled 33 patients over this time period, and the completion rate was very high. Patients tolerated this treatment well. Even the 4 patients that did not complete all 4 cycles was because they had progression elsewhere, like liver metastasis or lymph node metastasis, that we had to switch them to second line, not because of intolerance to treatment. And that's what I'm showing here, 4 out of 33. And the grade 3 or higher adverse events, which is how we generally assess tolerability to any new approaches to treatment based on adverse events, right? So the symptoms that the patients have were minimal. And these are just anemia, the typical things that we would expect with gastric cancer. And I am happy to share with you the survival results of STOPGAP 1 that are yet to be published. So these are unpublished results. I think it is published in an abstract form in JCO because I presented this data recently. But what we were able to show is, yes, there is the median overall survival from diagnosis was 17.8 in these overall patients. But I want to draw your attention to the group that underwent cytoreductive surgery. I was able to offer surgery to 14 patients. That is about 43% of patients who were enrolled in this trial underwent cytoreductive surgery. And in the patients who underwent cytoreductive surgery, the median overall survival from diagnosis was almost 38 months. Right? And the median overall survival since they participated in study was almost 33 months. Right? So we started with a 6 to 12 months survival. And here we are. Yes, small number of patients is a phase 2 trial, but there is a signal. There is a very strong signal that when you appropriately manage these patients and get them to surgery, just like what was shown in the Chinese randomized control trial, there is a subset of patients who would live a lot longer than the 6 to 12 months that is currently being projected for these patients. So this is a very important result. And this is the result, and I'm just showing the Kaplan-Meier survival curves, and you saw the overlapping curves. I showed you the overlapping curves where the lines were falling on each other. And here is where the lines are separating from each other. And the blue line represents the patients who were able to undergo surgery. Right? And this is PFS, which is progression-free survival. And here is the overall survival. And I can see the curves, they're not even close. They're not even close from the very beginning. Right? And 33.3 months on study, or 38 months from diagnosis. Right? This study resulted in me taking these results to the ECOG group, and I showed them as to how safe and feasible this approach is, and also the yearly survival results that we were starting to see, and finally was able to get them to come on board and support a much larger national randomized control trial, which is currently open and accruing, that is the EA 2234 stopgap 2 trial. So this trial is exactly the same as stopgap 1, but the question that it is trying to answer are twofold. One is, again, duration of treatment matters and selection of patients to surgery matters. Right? And the duration has to be at the minimum 6 months before you select patients for surgery. And that is one thing we are going to test, is because in this study, patients with gastric carcinomatosis will be randomized 1:1 to either continue the systemic therapy for an additional 3 months or receive systemic therapy plus that intraperitoneal chemotherapy for 3 months. So either ways, both arms are going to get 6 months minimum of treatment, because for entry, they need to have received at least minimum 3 months, max of 6 months of chemotherapy. First line systemic chemotherapy, right? So that's important that they are on first line systemic therapy. And after 3 to 6 months of first line systemic therapy, if they just have intraperitoneal disease, meaning peritoneal carcinomatosis alone, they will be eligible to participate in the stopgap 2 trial, and they can go either ways into continuation of the chemotherapy for another 3 months, or intraperitoneal and intravenous chemotherapy for 3 months, after which they will then be evaluated. And for patients who have response and who have very limited disease, and we quantify disease based on peritoneal cancer index, and that is what the PCI means. So when they have low burden disease of less than 7, according to the peritoneal cancer index assessment, and a complete site reduction is feasible, they are offered surgery on both arms. So all patients who enter this trial have a shot at surgery. Because when you look at the data that I showed you, the no CRS group in the intraperitoneal paclitaxel could be just as good as giving chemotherapy, systemic chemotherapy. Right? So when I look at my own data, I can't convince myself that the intraperitoneal paclitaxel is the one that completely changed it. What I can convincingly tell myself is that surgery matters. Surgery matters. And whether intraperitoneal paclitaxel adds more to what we are doing is not sure. So that is why it's completely appropriate for us to put the patients into either continuation of systemic therapy or intraperitoneal paclitaxel, but offer surgery to both groups. Because in my mind, surgery does matter when you're appropriately selecting patients for that surgery. And so this is the EA 2234 STOPGAP 2 trial. It is open across the country in many major peritoneal malignancy centers, and more centers are opening up. Right now, I think we are open in at least 20 different locations, and many, many centers are currently coming online. The trial was activated on August 19. And we have already enrolled 30 patients in the trial, and we are accruing every single day for this trial. It's a very important trial. And I will say this is the first NCI-funded carcinomatosis trial. We have never had an NCI-funded peritoneal carcinomatosis trial. So this is the first one. And since then, we have had two more approved. So I think we have opened up the gate for NCI to look into this disease process more closely and understand that there are surgeons, groups like us, who are dedicated to changing the treatment of these patients, and they see the strength of our group and the ability to be able to accrue patients into these trials. And here is the regimen that has it. And I'm putting this out there in my slides is because people are going to look into this presentation and look for more detailed information about who is eligible and who is not. And that's why, even though this is a dense slide, I wanted to have this information available to people who are looking into the eligibility criteria. And very similar to STOPGAP 1, it is just that patients should have just metastasis to the abdominal cavity and not elsewhere, and should have received at least 3 months of that first line chemotherapy. And there are some study site requirements. I know this is a very important trial, and we want to make sure that the sites that are opening are highly qualified to take care of these patients. And that's our responsibility to patients, right? As the PI of this trial, I have responsibility to ensure that the sites have appropriate capabilities to take care of patients. So we do have that. And here are the endpoints of this trial. The phase 2 endpoint is progression-free survival, and phase 3 endpoint is overall survival. The total number of patients required is 148, and the results of this trial are expected in 2031. I am hoping that if we accrue patients at a much faster rate than what had been projected, we may have the results of this trial a lot sooner than 2031. And that's the hope, and that is what I'm working so hard along with many other partners to ensure that we are spreading the word about this trial, making sure we are accruing patients to this trial, that patients are aware of this trial and they can advocate for themselves to say, what about STOPGAP 2? Am I eligible for STOPGAP 2? I want to possibly have this chance at having my cancer surgically removed. Because this one doctor told me that, and it is true, and I do believe it, that surgery has a role in patients with stage 4 gastric cancer, but it has to be done in a very thoughtful way by highly uh, skilled experts. This is not a surgery that should be done anywhere. It should be done by skilled experts because it is technically challenging and in appropriately selected patients. So these are all institutions that currently have either STOPGAP 2 opened or currently in the process of opening STOPGAP 2, and there are many more that are coming into line with STOPGAP 2. And I just want to acknowledge all the partnership and support from so many different groups, surgeons, medical oncologists, pharmacists, and organizations like Alliance who are willing to spread the word and are giving us the opportunity to be able to talk about this important concept. And here is my core, exceptionally brilliant, hardworking team in so many ways that have made any of what I have discussed today possible. And I appreciate your attention, and I will be happy to take any questions.
This is so great. Thank you for sharing. I want to remind participants, if you have a question, to pop it into the Q&A box and make sure it's selected for all. I will get through them, but I do have a few questions. Dr. Senthil, you mentioned that gastric cancer in the US isn't as prevalent as in Asian countries, and in the US, it seems to be clustered around that New York, New Jersey, California, Alaska. Do we know why?
Well, it's a combination of many things. One is the the multi-ethnic population that is prevalent in the coastal regions. An immigrant population also changes the incidence in those regions. So in California, we do have a lot of immigrants from Mexico, and they have a higher incidence. So Hispanics have a higher incidence of gastric cancer and higher incidence of stage 4 gastric cancer. Now, there's a lot of theories behind it or hypotheses behind it, and one of which is exposure to Helicobacter pylori, which is an infection that occurs in the stomach due to drinking contaminated water. And that infection increases the risk of gastric cancer. And that is not to say all gastric cancers are the cause or caused by H. pylori infection. I think it's just the combination of things that we see uh, about the multi-ethnic population, the immigrant population, their own predisposition for gastric cancer and their early childhood exposures and the influence of those early childhood exposures and the incidence of gastric cancer. So it's multifactorial. Any of what we are seeing, the directionality that we are seeing is multifactorial.
Okay. Question. How would a patient become eligible to participate in stopgap? If they were interested, how does that happen?
Yes. So the first thing is that obviously a discussion with a medical oncologist and understanding if the cancer spread is limited to the peritoneal cavity is the first thing. And the next is they need to have had some amount of systemic therapy, the 3 months minimum, to become eligible. So if a patient is being presented with a diagnosis of, say, stage 4 gastric cancer, unfortunately, and the doctor is having a discussion that this cancer has spread to their abdominal cavity, either as microscopic cancer cells or evidence of disease, that by itself is sufficient for them to discuss stopgap 2 trial, is because you wouldn't know where the patient is heading at that point. And only time will tell after 3 months of systemic therapy if the disease is confined to the peritoneal cavity. And it's really important for people to make that call and have a yearly consultation with a surgeon who manages peritoneal malignancy. And most of the peritoneal malignancy surgeons in the country are aware of stopgap 2 trial at this point. And just information is important, and having that consultation and figuring out if this is an option to make sure you would be eligible 3 months down the road. And that's crucial. And so we work very closely with our medical oncologists. Since you're asking that question, Amy, I also want to highlight, right now there are many phase 1, phase 2 clinical trials for gastric cancer with novel agents and antibodies and other things. And yeah, it's appropriate to keep enrolling in those trials as well. But it's important to put a word of caution. If patients are enrolled in other clinical trials as the first line treatment, say they get diagnosed with gastric cancer, and as the first treatment itself, they're getting into a clinical trial instead of the standard first line systemic therapy, those patients will not be eligible because the requirement for them to be eligible in stopgap 1 is that they must have received 3 months of first line systemic therapy, which is pretty awesome at this point because we have Folfox and Nivo or Folfox, trastuzumab, pembrolizumab, or zolbetuximab. So these are proven well tolerated. I wouldn't say well tolerated, but however, regimens that have been shown to have improved survival benefit in patients with metastatic gastric cancer. So we want them to get the best of best first line systemic treatment. So that's all that is required. The awareness and being on first line systemic therapy, having a yearly consultation with a peritoneal malignancy surgeon, and setting themselves up to be enrolled.
If someone had spread to their spine, would they be eligible for this trial?
They wouldn't be. They wouldn't be. So the main requirement for eligibility is that the cancer spread must be confined to just the abdominal cavity. Because once it is to the abdominal cavity and to the spine, you now have a multi-metastatic disease or multifocal metastatic disease. So the stopgap 2 trial is designed for a unifocal metastatic disease, not multifocal. We do have, for those patients, I get this question all the time, Amy, because
Hmm.
you don't get patients in a selected bucket, right? The disease can manifest itself in many ways. So we are just about to open a trial in at UCI, which is called the Stopgap B, which is a basket trial to address these type of issues where patients now have metastasis elsewhere, very, very limited oligometastatic disease elsewhere, and do have peritoneal disease. So in those patients, we now have a trial to see how does this bidirectional treatment, having that intraperitoneal paclitaxel and systemic treatment would be helpful, whether it is feasible, can we do this safely? Right. So we do have a trial for patients like that. It will not be stopgap 2, but it will be stopgap B trial that they could participate and receive that intraperitoneal paclitaxel treatment.
And if somebody was interested in learning more about that, how would they do that?
Okay, they can reach out to me. I will please share my email. Amy, I should have put that in my presentation. I apologize. If you could just include my email.
Or you can
One,
email me and
yeah,
I can forward it on to you at
please
A
do.
Hanley.
Please do. And my email is available pretty much everywhere in the web. It's m.senthil@uci.edu. And one email to me, and we will take care of you. That's all is needed. One email, m.senthil@uci.edu.
Okay. Another question. What is different about Stopgap 2 compared to any other trial available for metastatic gastric cancer?
So in the US, Stopgap 2 is the only trial that offers surgical resection for patients with stage 4 gastric cancer. That's it, period. There's no other trial that offers surgical resection for gastric cancer, particularly gastric carcinomatosis. And you have seen the differences in survival in patients who undergo surgery versus no surgery. Right? That by itself makes this the most important trial that patients should consider if they do have gastric carcinomatosis. Because a shot at that surgery, and it cannot be predicted up front, right? I've seen patients with pretty extensive peritoneal disease that we are able to offer surgery. And so a shot at that surgery makes a big difference. And that is, I would say, is one of the biggest differences between Stopgap 2 and any other trial that's available for metastatic gastric cancer, particularly gastric carcinomatosis.
Well, other than these two trials, are there other options available for patients or how do they find out about them?
Yeah. So, the most important source of information should always be your physicians, right? Meaning they should be well informed to discuss here are the best trials based on the biomarkers because gastric cancer treatment trials right now are biomarker driven. We are looking at the tumors and the biomarkers that are expressed in the tumor, whether it is Claudin 18.2, PD-L1 expression. And based on those biomarkers, we then decide what might be the best treatment for this patient, including the eligibility to participate in a trial. Say, for example, a patient has peritoneal disease, also has a bone mat, would be an appropriate candidate to participate in any one of those phase 2 trials that is looking at a novel monoclonal antibody combination or bispecific antibody combination treatment. Now, these, whether it is available at your institution and so on, is done through your medical oncologist who should be well informed to be able to speak to you on that aspect. The other source of information, like the global source of information, is clinicaltrials.gov. So, clinicaltrials.gov does provide the list of clinical trials that are open or enrolling for any particular disease. And that is a source for patients might be it requires certain specific ways to search that trial website. It may not be as easy to navigate that trial website because it's intended mostly for professional consumption. However, it's still a source. But our responsibility is as providers to be able to speak to what might be the best option for patients, both standard of care versus clinical trials.
Okay, I have one more question. In your slides, you showed that in order to have surgery, you wanted somebody to have a PCI score of 7 or less.
Mhm.
What happens if somebody has a PCI score greater than 7, but they are stable?
Yeah, so that is one. So let me continue to share. Let me show you this. So this is
Yes.
what happens, right, in those patients if they can continue the assigned treatment. If the PCI is more than 7 and they are not eligible for surgery at that point, but they are responding to treatment, we can continue the treatment, including the intraperitoneal treatment. We have patients who get 10, 12 cycles of intraperitoneal chemotherapy. So that is an option and they can be reevaluated. This is the first reevaluation that is shown in the schema happens after 3 months. And so they can continue the treatment and they can be reevaluated again for how they are doing. Yeah, that's an important question. So we do have that subsequent follow-ups and reassessments and making the next set of treatment uh, decisions is because it always evolves, right? Based on how the patient is doing, how the disease is responding, and what are now the appropriate treatment options for the patient.
Well, this was wonderful. I don't have any other questions in the chat. And I've gone through quite a few that were submitted in advance. So I just want to thank you again for your time. Thank you everyone for joining us. If there are additional questions, you are welcome to contact me, contact the Alliance. I can get a message to Dr. Senthiel very easily. But I appreciate everyone for joining us this afternoon. Thank you so much for spending your afternoon with us, your morning, and hopefully things go well.
Yeah. Thank you, Amy, and thanks everyone for joining. Appreciate your participation.